interpretation today, an Arabic interpretation as well, but that will be in the Japanese channel. Our lovely moderator today is Therese McGinn. Therese, let us know once you're all set and we can get started.
Okay. So I hope everyone has seen these, the choix de langue, the language selection slide. I'm going to turn that off now.
We do not see the slide, so
We don't see your screen.
Okay. I'll put it up for just a moment, so you can see it. So you go to the interpretation bar. Okay. Greetings and welcome to this session on catalyzing change for contraception and abortion care in fragile settings. In 2006, a large anonymous donor began a far-sighted, strategic, and generous program to do just what the title says, to catalyze change so that refugees, internally displaced, and local populations affected by crisis could get what they wanted, they needed, and they had a right to: contraception and abortion care. I hope it will sound unbelievable to those of you who know the field today that prior to 2006, there were hardly any sexual and reproductive health and rights services available to these groups. Maybe you'd find pills and condoms in here and there in a few sites, but no broader range of contraceptive methods, and certainly no safe abortion care or post-abortion care. There had been some progress in the prior decade, but it was slow and spotty. This donor's vision and support transformed everything. They funded the RAISE initiative, based at the Mailman School of Public Health at Columbia University. I was its first director. This was a global network of implementing research and policy organizations whose fundamental mission was to redefine humanitarian organizations' practice of business as usual, to include sexual and reproductive health and rights services. So we designed a system that established these services on the ground, strengthened international NGOs' commitments and capacity to deliver these services, and pushed funding and policy changes in international organizations, in host and donor governments, in private donors to promote the sexual and reproductive health and rights in crisis. And this donor didn't stop with RAISE. They do much more to promote these services in crisis. They support Ipas to help humanitarian organizations provide PAC, post-abortion care, and SAC, safe abortion care, which these organizations had never done. Virtually all of these collaborating organizations that were involved in the beginning and throughout this donor's funding for crisis are the leaders in the field today. They're amazing. They've done so much. They're the drivers of service and policy improvements in crisis settings globally. Moreover, the donor supports IAWG, the Interagency Working Group on Reproductive Health in Crisis, which convenes these and newer groups to promote cross-learning and standards. IAWG is crucial for the expansion of comprehensive SRHR services to new partners, new sites, new clients. I'm going to show you a few slides. To illustrate the changes that have been observed during RAISE and the related programs that the donor has funded. Can you can see my screen? Yes, okay.
Yeah.
So catalyzing change for contraception and a comprehensive abortion in fragile settings. The program has invested in 32 countries in all regions of the world. Lots of health districts, lots of health facilities, major changes in health facilities. Lots of new users, lots of women, men, adolescents who've had access to methods. A big focus of the program was LARC, long-acting, reversible contraception. Again, new in virtually all of these settings. Lots of PAC, post-abortion care clients. A big push, again, for quality of care was post-abortion care clients who then would continue with contraception so that they wouldn't get pregnant again and require PAC or be vulnerable to pregnancy complications, and SAC clients, safe abortion care. So again, numbers over this period. Now, to do all of that, you needed lots of trainers, you needed training of trainers, you needed master trainers. And again, large numbers of those people trained throughout the world and supported and supervised and again, and their skills maintained. None of this was an easy task. There were lots of milestones. The milestones are about services, the launch of services, about the launch of the systems changes we need, training, logistics, supervision, all of those systems that had to be in place for the services to actually work. Policy changes. So getting SAC, for example, and comprehensive abortion care in the interagency field manual. Again, setting standards for the field. All of the partners that were funded by the donor were involved in all of these activities. And without the support and without the partners, none of them, they wouldn't have happened, or they would have happened much later. Lots of data collected and analyzed and applied with conferences, with published papers, and then certainly throughout, but especially with a focus in local years on transferring to local partners. There's always been collaboration on the ground, but that has been a focus, a very strong focus of late, and needs to be stronger. So I'm going to stop the screen share there, and I want to invite you to a discussion with some leaders in the field who've been around for working on this topic for a long time. So we can say, as the graphics show, the progress from 2006 to today is truly remarkable. What we've just seen are the tangible change, the tangible achievements, number of people trained, number of women served, stock shelves, data systems. And all of that meant that women, adolescents, and men could come for services and actually get them. When they arrived, there were services available for people to actually use and then go on to live their lives as they chose to live them. But much of what was created by the donors' support was an environment that allowed the progress within the agencies that it's not easily counted in numbers. So that's what we're going to discuss in this panel, to discuss how these shifts came about in the organizations. We have a panel of 4 professionals who've been involved from the start. Dr. Ripka Amsalu was the Senior Emergency Health Advisor at Save the Children and is currently a research fellow at the University of California, San Francisco. Dr. Jessica Kakesa is a medical doctor with more than 10 years of experience in humanitarian settings across Central and East Africa. She is now at the International Rescue Committee as a health technical advisor and provides support to the Great Lakes region. Bill Powell has been with Ipas for over 16 years as a senior advisor supporting Ipas's efforts to improve access to safe abortion and post-abortion care in crisis. Bill has served as the Ipas liaison to IAWG for the last 14 years and is serving on several key committees at IAWG. Jessie Rattan was the Director of Care Supporting Access to Family Planning and Post-Abortion Care Program, SAFPAC, from 2011 to 2016, and is a longtime and passionate member of the SRHR team at CARE. She's currently an NIH trainee, writing her doctoral dissertation on racial disparities in maternal mortality in Alabama, the United States. Okay. So I'd like to invite the panelists. Two features of the design of this initiative were that we established a collaborative network and we had substantial funding. Again, the donor was very generous and multi-year funding. So what I want to ask you, let me start with you, Rivka. How did this affect your organization's decision to commit to sexual and reproductive health and rights in crisis?
Good morning, Therese. Good morning, everyone. It's lovely to see colleagues that I haven't seen really for a long while from SAVE and others. So thank you for the organizers for organizing this and just allowing us to catch up as well. I mean, I would say, I think I'll go way back to the RAISE initiative. And I would say, I think there were a combination of factors really that helped move and have an agency commitment. First, I think I want to thank you, Therese, and colleagues from Colombia who used to come to Washington, D.C. office to meet our senior leadership and then share your experience. And that kind of added credibility to what we were advocating for internally as technical advisors. I would also say the intentionality of the donor from the get-go. I mean, they kept on saying, we are committed to you as long as you deliver on A, B, C, D. And that was a long-term vision and commitment to the organization. I think that was communicated to the highest level of the leadership at Save the Children back then. So I think that kind of like helped secure our vision, but also allowed us to think beyond the grant period. There was a large amount of funding that was allocated for headquarter capacity building alone, that enabled us to hire qualified advisors, M&A person, communications, advocacy trainers, and that was obviously needed. I mean, without that, we wouldn't have been able to do it. So I think that was a good push and a good commitment from the foundation. There was another element, I think I would say, kind of like a peer-to-peer pressure among the organizations. We used to have annual meetings in various offices. And I recall the one we had in Westport at Save the Children, where the CEO of Save the Children was able to come and join us for a few minutes. And I think that level of higher senior leadership collegiality or connection enabled them to do or make commitments that probably wouldn't have been happening if that didn't happen. I mean, let's say if IRC did it, then Save the Children may be able to commit to it, or if CARE does it, maybe we can do it as well. So there was that some level of peer-to-peer learning, but also sharing of decisions at a higher level. Finally, and I think for me, this was the critical piece, the results, the impacts we were seeing in the various countries were visible, they were tangible, not only just the data and the quality of programming, but the acceptance by the community, the acceptance by our country team in these various conflict-affected countries, the commitment from the Ministry of Health. And I think that was coming back in terms of reports, feedbacks to our senior leadership. And I think all these factors somehow contributed to enabling Save the Children to make the commitment. Thank you.
Thank you, Rivka. Jesse, how about you? Your position, you were at CARE. How did these, the multi-year funding, the networks, how did that affect CARE's decisions?
Right. Thank you so much. And it's really is so great to see people. I just am so happy to be here talking about this and reflecting. So 3 things for me when I was thinking about this, reflecting, what did collaboration, the collaborative network, and what did the multi-year funding do for us right out of the gate? So number 1, it helped us prove the point, right? These aspects of the program gave us the resources, the talent, and the mind share to demonstrate with high quality data that this technical stuff, this sensitive stuff, is actually doable in acute and chronic crisis. And in fact, there is high demand for it. And we were able to do that really fast. And I think it even I remember being surprised and worried. I'm like, is this the real stuff that we're seeing? That right out of the gate, proving with the monitoring data really helped. It also gave us time for culture change. Multi-year funding, from my perspective, can really feel like a rarity at a big NGO. And this funding allowed our talented teams in some of the most unstable places to learn, build skills, build relationships, grow their networks to do the diplomatic, long-term relational work that is needed for a culture shift. And this was happening in the organization, and it was happening in the regions and the countries and the places that we were. So that space for culture shift, which ultimately underpins this complex and difficult work. And then finally, kind of related to that, really good evidence. So the program priority out of the gate was really good monitoring data and help from the Columbia team as our sort of M&E evaluation partner to build those systems, and that capacity really helped. Standardizing the monitoring components across our organizations and countries gave us the power of the reach of those numbers pretty fast. Also, it gave us a space to look cross-organizationally and compare. Are we seeing differences? Are we seeing the same dynamics happening? Because we were individual organizations, we were sort of encouraged to innovate ourselves, but at the same time, we could come together and brainstorm the way Ripka was talking about, come together and problem solve and brainstorm, both kind of at that global level, but also in the regions or the countries themselves. So those are kind of my three top.
Thank you, Jessie. Jessica, I'd like to ask you, you were in the field this whole time and from early days as well. What was your reaction to that? What did the multi-year funding and this network support do for your programs on the ground?
Yeah, hi everyone. And again, thank you for letting me be here. I'm so happy to see these faces. It has been a long time. Yeah, so I think this opportunity of having this multi-year funding and multi-year programming has allowed us to change the way of doing things in the field. So in collaboration with the MOH, we were able to start with training, capacity building based on skills. So it has been like trainings were happening, true, but with the initiative, we were able to innovate and try this new training based on skills, having trainings and having trainers. I would say we were like having a pool of trainers who could then cascade down training, so which then will lead of trainings on a higher scale and have many providers trained. And again, we were also able to maintain this provider in the program on the long run, which is also key when you train people, especially with what comes after the training, which is the supportive supervision as well as coaching. And beyond training, we were able also to improve the monitoring and evaluation system, even where it starts. I remember we had at first to add columns with a pen in registers to be able to collect information like the number of complications. And we were able to bring that and have national registers with all this key information integrated in it. And of course, the training has to do also with management issues like even drug management, which helps also to improve quality and availability of services.
Thank you, Jessica. This brings back all the memories. I mean, the registers. Oh gosh, how many person years did we spend on registers? Bill, you work at Ipas. Ipas focuses on SAC, PAC, and CAC, safe abortion care, post-abortion care, comprehensive abortion care. Those are sensitive topics in these organizations which were not traditionally provided even very broad reproductive health services, and certainly not abortion services. And moreover, in crisis, which was not IPAS's original focus. So what was it like for you? Tell us about the early experience of you working with the donors' support with the crisis or with the humanitarian organizations.
Yeah, thanks, Teresa. IPAS has been a part of the IAWG, the fabulous network that IAWG is and represents, and its work for decades, but serving primarily in an advocacy role. So this multi-year funding really allowed us to do what we do and have done for decades, and that is to build an enabling environment and capacity for providing safe abortion care. But it was just with these new partners and in their context, the places in which they were working, which were not places that Ipas had commonly been. With safe abortion, as you insinuated, it's really rarely a one-off training that gets services being offered. And we knew from decades of safe abortion work that it takes time and different types of engagement with partners to eventually get safe abortion services. So the longer-term funding provided the time for the necessary discussions with partners, the values clarification or VCAT work that is usually needed before any technical training, and then enough time to get to the technical training and training of trainers on all of this content to transfer that capacity for sustainability to our partners. So as Jesse said, it's a culture shift, and that takes time and different types of engagement. It's not just the technical piece.
Sure. Thank you. Now, as we've said, much of RAISE and the other, I think it's fair to say the RAISE and the other early donor-supported programs really did focus on international organizations. Now, there've always been local partners, and I think it's really important to remind people that virtually all of the programs in all of those countries you saw on the map were with Ministry of Health, with local, with government systems, with national systems, and Jessica referred to that working nationally was really important. However, the focus really still was, the support was just international organizations. What do you think has to happen going forward about with localization? Let me start with you, Jessica.
Yes, thank you. Localization is really key to future expansion of SRE services. We've seen that we've accomplished a lot, but at this point, we know that there are women out there and young girls who can still not have access to services. So empowering this local organization and making them able to have that capacity to influence SRHR is key. This organization, while the context first in which we operate is a context of protracted crisis. It lasts long years, and we know that these local organizations are there at the onset of the crisis. So they are always there, they're there first. They really know well the context, and also it's easy to have great acceptance from the community because they are there from this community. And so far they have shown also, they have played a key role. For example, when we look at what has been achieved in terms of advocacy. So this local organization coming from a civil society organization has been very key in accomplishing these successes.
Thank you. Thinking about the view from headquarters, how would that work, do you think, from a headquarters to really focus on or to support local organizations more? Ripka, what are your thoughts on that?
I think in a way, as we move through the phases of the funding, there were several changes that we had to do at the headquarter level. And I think if one thinks localization or expansion or scale up that way, it may help in a way, because I think the steps or the milestones we took as an organization in Save the Children could also be applicable to any other organization,
yes,
anywhere. And I think a couple of things helped, I would say. First, I think having highly qualified staff at the headquarter level for us, and for me especially, was really helpful. We had technical advisors, Maria and Janet and Sarah, and M&E experts, training experts like Virginie. It was a coalition of really various skill sets that came to the pool, and having that really helps to to implement a quality program or even to scale it up or move it forward. So I think any future structure or strategy to scale up a program at the country level should think of having that centralized capacity with multiple skills. And you shouldn't expect people to know everything. So having that multiple skills does help. I would also say, I think for SAVE, having the foundation team at Save the Children, and I see Megan here, and thank you really very much, because I think they do help with managing expectations from your leadership, but also in terms of managing the donor. I think, as we all know, the donor is highly demanding in terms of what they want to achieve and what they want to see. I remember writing reports that took forever to finish, but having that committed staff helps navigate the system, be able to do your achievements and your milestones on time, and also kind of like reassuring your senior leadership that you are on track to achieve what you promised to achieve at the beginning of the year.
Yeah.
And the other thing I would say, I think, is if you go now to clinics in even way back then in West Darfur, Sarah, we remember this. You would go to a Save the Children supported clinic or hospital and see all the resources there, all the data showing high achievements, and the collegiality you would see between Save the Children technical advisors and the Ministry of Health staff and the actual service providers, the nurses and midwives and the clinics, shows you kind of like a close working relationship. It wasn't a supervision visit to judge or critic, but it was more of, let's do it together, let's achieve together. So I think that kind of supporting and reinforcing the actual service providers in the field in these remote locations is quite critical. Whoever is implementing it, whether it's an international NGO or local NGO, having that support structure to the clinics, to the nurses and midwives, I think is vital in having a quality program, I would say. Thank you.
Thank you. Jesse, what are your thoughts on this? But also, what closing comments would you like to make?
Yeah, I think if I'm going to try to think about like a connecting point for myself, I think that getting to scale is about localization. I wish we had a more empowering word than localization.
Yeah.
It undersells the power of what we're trying to do as a international development sort of sector. But I always lean back on a little bit what Ribka was saying about the collegiality, the relationships, that really exquisite relationships that our teams in various really difficult, complex setting, the relationships they have with the local ministries of health, with the local civil society organizations, and how do we support those relationships, that capacity, those connections in settings of intense change and complexity to do this hard work over the long term.
Thank you. Bill.
I won't repeat any of this stuff on localization. I think that's clearly a direction we're all working on and need to go. And it also gives us the opportunity to think about preparedness and not, just focusing on the response. So that's another direction that localization, I think, really enables. But I just wanted to say that we have a really fabulous success story here we're telling today, I think, of change that has happened. And yet, with all that's happened, it's still a drop in the bucket. And we know that in most crises, whether conflict or climate driven, women and girls, people that need these services are likely to not find them, or at least they're going to be of low quality. Despite their rights, despite their needs, despite the local laws that usually allow services to some extent. And so, the work is just beginning, really. This is a story of what can be done. And we've shown it can be done, but there's so much more to do. So.
And that's a very good closing message for this first panel of today's session, because it is. I mean, I look back, having been involved from the very start, and it's astounding to me. I mean, lots and lots of women and girls and men around the world can get what they deserve, can walk into a place, find services. And again, all that takes, we struggled with so hard for all those years. It happened, and we know it can happen, and it is, and yet it's still the case, as several panelists have said, most people in the world, most refugees, IDPs, and local populations do not have access to these services. So we are far, far, far from done. But I think a difference certainly now is that, again, virtually every organization represented here today is an unbelievable resource for moving ahead. I dream of a raise, of a donor, of a network like the one this donor supported, broader than RAISE, certainly, an IAWG that is truly global, that goes to all the local organizations, that uses these resources that we have to help and support local organizations to do, as Jessica said, what they know how to do, and what they need to learn how to do better, as all of our organizations did. I learned so much from the donor. Yes, Rivka says they were demanding. We'd sort of, and then you'd say, they're right. Okay, moving right along. And you did, and you learned a lot, and we made unbelievable progress. But it was with a lot of agony and a lot of money and a lot of long-term money. All of the things people have talked about, trust, relationships, culture change, for goodness sakes, in these organizations requires long-term support. So I hope that, and it was done. We did it. These organizations are leaders, and they can lead, they will lead with enough support and encouragement the next phase, which has to be moving to a more decentralized, a more locally supported model of research. It does my heart so well to hear all of the emphasis on data. I can die happy, right? Because we pushed it so hard, and it was critical. It was absolutely critical to make to the successes that we had, because it was evidence. So the services need to be improved. All of the support systems, the data systems, the research, the policy, the advocacy. I'd love to see that as to continue the phases that have already been happening. Thank you all to the panelists, to Bill Powell, Jesse Rattan, Jessica Kakesa, and Rivka Amsalu for participating in this panel. And I look very much forward to the breakout sessions and the rest of the panel, which will include breakout sessions, which will go into more depth on some of these very topics that these panelists raised. So thank you very much. And it is wonderful to see so many old colleagues and friends. Thank you.
Hi, now we're going to hear from some of our local partners that worked with us over the years. We have a video with a representative from the National Reproductive Health Program in DRC, from a midwife who was working at a health facility in North Kivu, DRC, that was supported and throughout this program and received training, and Zawadi, a local partner that we worked with DRC.
Un projet vraiment intéressant. Bon, je suis Dr John Muzige, je suis le médecin coordonnateur provincial du programme national santé de la reproduction Nord Kivu. En fait, nous avons eu à mettre en œuvre le projet CONCAS, mais c'est un projet qui est venu après un projet vraiment intéressant de SAFPAC, mais ce projet est arrivé après l'épidémie d'Ebola. C'est que le projet couvrait la partie zone de santé de Goma, mais aussi la zone de santé de Karisimbi. Et comprenez que la zone de santé de Karisimbi, la partie nord, il y avait vraiment une épidémie à la maladie, à la virus Ebola. C'est que par rapport à ça, c'est que nous avons vraiment eu les changements hein, c'est que les projets prévoyaient effectivement les aspects de planification familiale et soins après avortement, mais aussi les aspects des soins complets d'avortement centrés sur la femme. Et nous avons eu à travailler, mais dans un contexte plus particulier. Et donc, par rapport à la partie de la province, il y avait aussi des aspects qu'on pouvait vraiment s'asseoir et intégrer parce que si une femme venait en train de saigner, il y avait des possibilités et aussi dans l'éthique qu'on puisse les mettre au compte de la maladie avec Ebola. Et là, nous sommes dit non, il y a vraiment des avortements spontanés. Et là, on devrait effectivement équiper, former. Et ça, on a fait les plaidoyers pour qu'on puisse intégrer la SR, pour que ce soit la planification familiale, mais aussi les soins après avortement. Alors, quelle est vraiment la chose qui est dans ces projets, que ce soit dans la partie nord de la province et même dans la partie sud, les gens ont compris par rapport à l'approche Vicati, les aspects des soins complets d'avortement, que ce soit au niveau des prestataires, que ce soit au niveau communautaire, dialogue, dont on a toutefois intégré. Mais la plus importante, c'est que par rapport à l'impact sur la femme dans notre communauté, et donc il y a déjà des structures disponibles dans l'offre et les populations sont informées. Donc, dans le contexte du protocole de Maputo, en tout cas, il y a des services Kagoma et même ailleurs pour les soins centrés sur la femme. Alors, par rapport à un impact sur le système de santé, c'est vraiment la pérennité. Donc, le projet est venu après. Les projets ne savent pas, mais les gens ont compris que vraiment les actions doivent être pérennes. Donc, dans les forçats, nous avons retrouvé, avec les refreshments, nous avons retrouvé l'offre de services de PF, l'offre de services de Sony, mais aussi, on a vraiment mis l'accent sur la PCI. C'était vraiment dans le contexte d'Ebola, donc on a mis...
Moi, c'est Madame Violette Massika. Je suis sage-femme. Je suis aussi la responsable du service de planification familiale et de gynéco-obstétrique à l'hôpital général de référence Virunga dans la province du Nord Kivu. J'avais suivi la formation de planification familiale et aussi j'avais suivi la formation des formateurs et des encadreurs initiés par Save Children. Cette formation a été bénéfique pour moi car depuis quand nous avons commencé, quand j'ai commencé à travailler, je n'avais pas bénéficié d'une formation pour la planification familiale. Et je ne savais même pas faire le counseling, faire une insertion d'édu ou bien faire une aspiration pendant l'avortement. Mais à partir de cette formation, en tout cas, j'ai bénéficié beaucoup et j'ai été apte à aider même les autres à renforcer leurs capacités et leurs techniques par rapport aux prestations des méthodes de planification familiale. Et à plus de cela, j'ai fait le counseling de qualité et je suis le point focal de cette structure pour la planification familiale. Et j'aide les autres, même dans la province, je suis parmi les formateurs professionnels par rapport à la planification familiale. Avant d'être formée à la planification familiale et soit après avortement, vraiment, je faisais les routines. On recevait les filles, les clientes qui provoquaient les avortements, mais on les recevait mal, puisque je n'étais pas informée. Et à part ça, quand la cliente est arrivée, on la faisait payer une amende, puisqu'elle avait fait un avortement provoqué. Mais quand j'étais formée avec Save Children, j'ai vu les bénéfices de soigner les femmes, même si elle a provoqué la grossesse, il fallait la prendre en charge comme toute autre personne. Mais ça a été bénéfique pour moi et pour la convaincre d'adhérer à une méthode pour ne plus faire cet avortement. Et avec d'autres clientes, avec les couples, j'essaie quand même de les convaincre pour prendre des méthodes à longue durée et même les méthodes irréversibles. Il y a des couples qui adhèrent ça quand je fais le counseling. Et ça a été bénéfique vraiment pour la communauté, pour le bien-être des familles et bien-être aussi dans la communauté.
Et moi, c'est Zawadi Bissomeko, secrétaire exécutive de la SAFDEF. Et la SAFDEF, c'est une plateforme des organisations féminines qui militent pour la défense, la protection et la promotion des droits de la femme et de l'enfant, créée à Butembo en 2003 et composée de 4 organisations, à savoir ADDF, FETSI, FJDEF et CIFET. Et le partenariat entre Care International et SAFDEF avec ses organisations affiliées consistait à doter l'organisation féminine SAFDEF des capacités de mener des actions de réponse en santé sexuelle et reproductive et de violences basées sur le genre dans les urgences humanitaires. Et ce partenariat a permis de mettre à la disposition de la communauté des services de qualité, notamment par le renforcement des capacités des prestataires et la dotation en intrants de planification familiale et la capacité d'offrir les soins après avortement. Le partenariat a vraiment renforcé les capacités organisationnelles, c'est-à-dire de gestion de la SAFDEF, et en matière de procédures de gestion, en matière de participation aux mécanismes de coordination humanitaire et a amélioré la qualité, l'accès de la SAFDEF au financement. Mais aussi, elle a permis à SAFDEF d'avoir des capacités techniques en matière de santé sexuelle et reproductive, notamment dans la planification familiale et l'avortement sécurisé, mais aussi la réponse aux violences basées sur le genre. Et donc, ce que nous souhaitons comme priorité, c'est que la SAFDEF ait les capacités techniques et financières des réponses à la santé sexuelle et reproductive et VBG, notamment si elle peut avoir la possibilité d'avoir un projet rédigé et réalisé conjointement avec Care International, avoir une formation sur la mobilisation des fonds, mais aussi développer une activité génératrice de revenus qui puisse lui permettre d'avoir des fonds et des réponses.
Okay, I would like to invite the panelists back, Bill and Jesse, and Jessica. I believe Ribka's had to leave us, but she'll come back if she can, for questions and answers. And I would invite all participants to please write your questions in the chat, and we'll answer as many as we can. I guess I'll start with a question. And it's been referred to a few times. I mean, I think this was, and we've just heard it in the videos, this was a work of passion, I think, for many of us. We really, this was critically important, and it wasn't just a job. Jessica, what do you, was that true for you, and how did it affect you in your professional life?
Thank you very much, Reza, for the question. And again, I'm feeling really, comment on dit ça?
Overwhelmed.
Nostalgic. No, it's really like I'm thinking where we started. When I joined IRC, I was coming from an organization where I was doing more health in general, not really with this much focus on women and girls. And then there was this opportunity, and with this focus on SRHR, and for me it was like a call. And just because when I grew up in Goma, in a context where there is insecurity, war, conflict, and all that. And I've seen, starting in 1994, when Rwanda's refugees were crossing the border, I was living just next to the border. I saw these children, these women suffering. And for me, this was a call on opportunity. And it was something I didn't see anywhere else. That's why even I decided to quit my job and join IRC. With this so much support system being put in place to support women and girls with these services. And at the beginning, it was not easy. People were reluctant and saying, I remember when we started even talking about IUDs in rural, remote areas, and they were like, are you really serious? This can't happen here. And then years back, when I saw what we were able, of course, with partners, able to accomplish where I was speaking to these women and girls and giving testimonies on how this have changed their life, I think it gives hopes. Actually, I know we are still far, and there are still women and girls out there still needing these services, but it can be done. It's possible.
Jessie, I see you nodding your head.
Yeah, it is a very nostalgic and powerful thing to come back and kind of revisit the feelings. You know, for me, I would say that the work was like a sparking or a firing of the heart, because it felt like, you know, how do you bring these high values, very abstract values of an organization like CARE or SAVE or IRC, down to the real world? How do you live those values? And I think coming together in community across countries in these small groups, and really, to be honest, working with the Ipas values clarification to ask ourselves, what do we want for our mothers, for our daughters, for our sisters, for our partners, for our beloveds? What services do they have a right to? Do they have a right to survive their pregnancies? You know, what can we do to make that a reality? How can we live into that? And to work across, you know, nationalities and cultures and people, you know, in those small moments was, for me, a peak experience. Therese, actually, you introduced me to that idea, the idea of peak experience. And so doing that, you know, bringing those big fancy conceptual ideas down to that heart change, to make small changes, you know, at the really the bodily level, was for me, yeah, like height of my career, really.
That's
Yeah.
wonderful to hear. I see that Sarah Ashraf has a question, but actually, and Bill, I'll come back to you, okay? Sarah, please go ahead. Dr. Sarah Ashraf from Save the Children.
Yeah, I just wanted to share maybe how the passion that you have asked us about, and that Jessie and Jessica have spoken about, how that actually translated over to frontline providers in these countries that we worked in, to many, many women within those communities. And a good example that I would like to share happened in Yemen recently with the COVID-19 pandemic. The facilities that we were supporting in Yemen, none of them stopped their services. The numbers for family planning kept going on. And it was because those midwives are just as passionate. It's because they understand this programming so well. It's because they're able to troubleshoot, they're able to work, and women in their communities have that trust in them. So I think that relationship cannot be built in 6 months and 1 year. It happened over the years. And I think this transfer of this passion to others, you can really see lives changing in the field. I just wanted to share that example, I think, yeah. And also I was thinking, some of us have given our like the majority years of our career to this work. Thinking of it, started working back in, I don't know, 2007, but all these years into this work and continuing to see changes happening, I think that there's a lot more to do. And I think that the feeling I always get is, I wish I could take this example to this other country, to this other community. Maybe they can also experience the same changes. Yeah, thank you. Thanks.
Bill, final thoughts.
Well, for me, my experience in humanitarian work began in the mid-'80s, when there was no reproductive health being delivered, and you know, was a second thought, if that. And so the opportunity through my work at Ipas to come to this work, and the amazing cohort of people that are involved with this work, particularly through the IAWG coalition, who really all have passion, you know, for this topic of SRH and crisis. And, you know, you don't work at Ipas if you're not sort of passionate about reproductive justice or reproductive autonomy, and particularly abortion care. So to be able to bring all that together and work with so many fabulous partners at HQ, in the field, and moving this work forward has really been yeah, it's been amazing experience. And like I said, something I hope we can find a way to continue, because the need
Yes.
is even, greater and greater every day. Thanks.
Indeed. Again, thank you very much to the panelists and to all of you for attending. And I'll pass over to Natalie, who will tell us about the breakout sessions, which are next up. Thank you.
Great, thanks, Therese. So now we're going to have an opportunity to break into smaller groups for more intimate conversations around a variety of themes. There'll be 2 rounds. One round will have a 25-minute discussion. You as a participant will be able to select the discussion you'll like to join. In the main room with interpretation, we will have a discussion. If someone can just go to the first slide, thank you. In the main room, there'll be a discussion around influencing government policy and practice around contraception and comprehensive abortion care. So you do not have to move anywhere. You just stay in this main room. A pop-up will come up on the screen, and if you're interested in joining a smaller conversation around comprehensive abortion care, you can choose room 2. If you're interested in talking about localization and the work that's being done on advancing localization for contraception, CAC, and sexual and reproductive health more generally, that conversation will be taking place in room 3. So there'll be 2 rounds. This is the first round. After 25 minutes, we'll come back and you'll get to self-select 3 more different topics. There was so much that was learned in this project and this partnership. It's really hard to discuss it all. So we hope that these smaller groups can give you just a little bit of a taste. So onwards, I think we're ready. So the breakout groups should be open shortly. If you go and click in the bottom to the breakout room button, you'll be able to self-select one of the rooms. So if you want to stay in the main room, we will be talking about influencing policy and practice and law. See you in just a short while. Okay, and one more reminder, the way that you get to the breakout rooms is on the bottom. If you click breakout rooms, it's the logo with 4 squares. That's where you can choose to go to the comprehensive abortion care breakout discussion group or the localization one. And in this room, we'll talk about influencing contraception and comprehensive abortion care policy and law. So we'll give everyone just a few minutes. Okay. Okay, Jessica, I'm going to hand it over to you so we can get started.
Thank you, Nat. Well, I would like first to welcome you once again all to this session on influencing contraception and comprehensive abortion care policy and law. Again, we still have interpretation services, so you can see at the bottom of your screen and click on the interpretation button and select the language you prefer. Today, we are going to really, in this session, we'd like to reflect on key points. Governments are key barriers and of course, governments are key duty barriers and partners in ensuring women and girls have access to contraception and comprehensive abortion care services in emergencies, but also NGOs play a key role in driving change in SRHR and abortion care policy in fragile and humanitarian settings. We are going to discuss some of the effective strategies that partners has used to realize this change. This will include one, leveraging regional human rights instruments like the Maputo Protocol, and also using program data and experience to advocate for change in safe abortion and task shifting for SRH services. Our panelists today are Justin Mumbere. He had worked with CARE. We also have Dr. Maing Poi, who is the program manager at Ipas DRC country office, and Maria Tolka, who is the senior reproductive health advisor from Save the Children. We will hear from their experience and have a Q&A session at the end, but also feel free to type your question in the chat. In 2002, the government of Chad passed a reproductive health law that was intended to uphold women and girls' access to sexual and reproductive health services. But 2 years later, the government also signed the Maputo Protocol, which affirms commitment to a wide range of services, including abortion care for numbers of indications. Yet, sexual and reproductive health care service providers and advocates for decades were not seeing this law translate into actions. We will now hear from our esteemed colleagues in Chad on why this was the case.
Je suis Dr Hélène, juriste de formation, donc j'enseigne à l'université de N'Djamena, j'enseigne le droit. Et par rapport à la santé de reproduction, je suis vraiment militante des droits humains. Je fais partie de l'association des femmes juristes du Tchad et on s'est battu pour justement ces questions des droits des femmes, y compris la question de santé de reproduction.
Bon, moi c'est Dr Grace Kodundo, je suis gynécologue obstétricienne de formation. Donc pendant longtemps j'étais le médecin-chef même d'une maternité en Ghana ici. Maintenant depuis je suis au niveau du ministère de la Santé publique comme ex-directrice de la santé de la reproduction.
Il faut d'abord saluer justement l'effort du gouvernement quand même pour l'adoption de cette loi parce que ça n'a pas été facile. C'était à la suite d'un grand plaidoyer, des lobbying, des travaux faits par les organisations de la société civile. Donc il y a eu beaucoup de travail qui a été fait pour amener le gouvernement à traduire dans les textes son engagement au niveau international. Malheureusement, une fois que la loi a été adoptée, elle a mis du temps pour avoir les décrets d'application, surtout en ce qui concerne les questions d'avortement. Mais pourquoi cela? Je voudrais dire qu'il y a plusieurs barrières politiques, parce que la prise de décision politique est très compliquée si au niveau de la politique, on n'a pas une bonne perception de la chose. Il y a aussi des blocages socio-religieux, socio-culturels, un problème de perception même de la question de la santé reproductive et surtout des questions d'avortement. Donc il y a aussi une contradiction, par exemple, entre la loi qui a été adoptée par le Tchad à la suite des engagements qu'ils ont pris et le code pénal tchadien qui interdit l'avortement. Donc vous voyez, mais ça au moins c'est une question qui a été levée parce que le code pénal qui a été révisé en 2017 a pris un tout petit peu en compte cette question d'avortement médicalisé. Et donc dans tout le processus, il y a eu des obstacles et autres grâce à l'action des différents intervenants dans le domaine, société civile, partenaires, État, on a réussi à faire des petits pas.
Alors cette loi, comme Dr Hélène l'a dit, il y a eu plusieurs facteurs. Et dans cette loi, vous savez, il y a aussi la question de l'accès de la femme, même par exemple aux interventions comme la césarienne. On demande l'avis de tout ce monde sauf celui de la femme. Et l'un des facteurs, c'est aussi le problème du statut de la femme, qui est un grand blocage. Donc vous voyez, c'est tous ces éléments-là pour lesquels il faut continuer à se battre. Beaucoup a été fait, c'est formidable, mais il faut encore continuer à se battre pour que la vie de la femme compte et pour que la femme puisse avoir l'accès aux soins qui doivent sauver la vie. La santé de la femme doit être également incluse, pas seulement la vie de la femme, mais la santé de la femme doit aussi être prise en compte dans...
Thank you. We just heard from Dr. Grace and Elaine in Chad about many challenges faced trying to advance this SRH law. I will turn to Justin to try to understand what they did to overcome that. Justin, comment CARE et d'autres partenaires ont-ils créé une coalition et comment avez-vous pu décrocher le décret d'application? Est-ce que Justin? Excusez-moi, je vérifie s'il est là. Ouais, j'ai l'impression que peut-être il a eu des difficultés à se joindre à nous, mais on va passer à un autre exemple et au besoin, on pourra revenir pour peut-être entendre encore un peu plus ce que l'équipe de CARE au Tchad a fait pour surmonter toutes ces difficultés. Alors, on va passer à l'exemple. We'll move to the next example, which is from DRC. So Advocate in DRC recently scored a significant advocacy and legal victory for safe abortion care in DRC after years of targeted advocacy and movement building. Dr. Mike Mpoi, can you tell us how SRH implementers and advocates were able to successfully integrate the Maputo Protocol into national law and expand safe abortion care access? You can help us describe the ratification of the Maputo Protocol and also to summarize efforts that partners took to push national integration of Maputo Protocol, including any use of program data experience for advocacy, especially in crisis-affected region of the country.
Thank you, Jessica, for the questions, and thanks to everyone for being here. I think the experience of DRC is, as other countries, a challenging time for mostly like civil society organizations that are advocating to have, or were advocating to have the different change. I should notice here that the legal framework for abortion in DRC started like in 1940s with a penal code that we inherited from the colonialization. You know, that penal code is kind of a copy paste of the Belgium penal code at that time, which was applied in 1930s in Belgium. And going forward, in 1970s, the president at that time, President Mobutu, took a decision to kind of lift some barriers, mostly which the one which was related to abortion in the penal code, because the penal code was punishing abortion, all cases of abortion, you know, with no exception. And then in 1970s, that law or decision lifted some barriers and make available the abortion for women health that is threatened by a disease or something like that. So that was like the only reason that was allowing women to have access to abortion. And some survey and studies that was done after showed that it doesn't reduce the number of abortion. And the only thing that it gets to do is to make abortion unsafe and really threatening women's life, and you know, bringing a lot of complications and a burden on the health system that was already really weak with all the problems that we know with like the local health system. So that in that circumstance, in 2003, there was discussion about the Maputo Protocol, and the DRC was part of those discussions, but we got to adhere to Maputo Protocol in 2008. And in 2006, we had first the parliament signing the authorization to allow the president to sign what we call Acte d'Adhesion, which is a document that is engaging the country in an international treaty. That was in 2008 and opened, the path to give possibility to civil society organization to advocate to get this Maputo Protocol published in the National Gazette. So that was a long fight because in 2008, the president signed it and we had to wait 10 years after, like in 2018, to have the Maputo Protocol gazetted. And in that time, we were facing opposition, we were facing all kinds of barriers, which was not allowing the Maputo Protocol to be published. I can remember like in Bukavu, there was even riots, like some rallies on the streets, people walking, saying that Maputo Protocol can't be applied in our country because it is allowing abortion and all of that. But, at the end, we got it. And that was the foundation was the use of evidence. We funded the Ministry of Health to conduct kind of a national assessment to evaluate the provision of abortion service and contraception services in the health system. And it came up from that survey that there is a urgent need to kind of bring new protocols and ways to provide services to reduce the complication that women was incurring in the service provision, like mostly for abortion. So I can say that this effort was done at the central level in Kinshasa to have new policies, to have a Maputo Protocol published and gazetted, and to have it applied as law, because our constitution in the article 215 is saying that when you have international treaty that is gazetted, it has a power over the national law. So that is the article that is giving the power to Maputo Protocol to be applied in DRC without the change of the penal code. And so now the Maputo Protocol is applied and is giving ways path to the provision of abortion services at all levels of the health system. That's why in east part of the DRC, for example, we've had interventions, like really quick intervention with what we call rapid opportunity funding that helps us to monitor the abortion ecosystem in general, to identify where the ecosystem stability is threatened. And the different components of that ecosystem, it's like political leadership and support. It can be policy and legislation. It can be the availability of commodity or the local expertise of health workforce. And all these are part of the ecosystem. When there is a problem or an issue with one of the components, we need to act really quickly to fix it. And that happened in the east part of DRC, for example, where we had some interventions in North Kivu, South Kivu, Ituri, Tanganyika, which are like the humanitarian setting, to address some difficulties that some local and international organization was going through, like harassment from police, law enforcement officers, or from judge. So we had to organize roundtables with political makers, with security people to address that question. And at the other side, we had to gather like civil society organization, train them and provide them with capacity to conduct communication at community level. So those are like really quick actions that we've made to make sure that we apply the Maputo Protocol as a law in DRC. Thank you.
Thank you very much, Dr. Mike. Thank you for sharing all these actions, which helps also to disseminate this new law at the provincial level as well. So we are going back to Justin. We have him on the call. So Justin, quickly, est-ce que Justin, vous pouvez nous dire comment CARE et d'autres partenaires ont pu surmonter les difficultés dont Grace et Hélène ont parlé dans la vidéo et comment est-ce que vous avez pu décrocher le décret d'application? Rapidement. Justin, vous êtes là? It seems that Justin, we've lost Justin once again. No worries, we will try again. So let's now discuss task shifting. And the third example is from Save the Children. The WHO has recognized task shifting as a promising strategy for addressing the critical lack of healthcare workers to provide SRH services in low-income settings. And access to healthcare workers is a significant challenge in fragile and humanitarian settings where health systems are significantly disrupted. So how did Save the Children work to extend access to contraception services through task shifting? Maria, I know you have a great example from Yemen.
Thank you, Jessica. We have a lot of examples from everywhere. I think it's very important for everybody to understand that task shifting is the front level policy change that you need to overcome in order to bring services closer to the women at the community, as many of the health workers and health centers in this setting, so they don't have doctors, or even if they have, the workload is so high. So task shifting is a very important strategy to consider from the early on of a program like this. So let me give you the example of Yemen. Back in 2012, 2013, midwives were not really allowed to insert or remove implants or even do like manual vacuum aspiration. These are all clinical methods that they are crucial in order to provide the actual service of family planning, as well as post-abortion care. So we advocated first at the governorate level to get a local level permission to conduct a small pilot and support midwives to insert and remove contraceptive implants and to provide as well manual vacuum aspiration. We did that by really demonstrating a very strong competency-based clinical capacity program. We really managed to convince the local authorities that our training program will actually give the skills that these healthcare workers are needed to provide the services, and it's going to be safe for the women that will take the services. With this data, we started very, very small. We took all this information from the pilot, and the governorates ended up really accepting the impressive results, and they really provide us more legal and generalized approvals for midwives to administer the implants and MVA, not only for our program areas, but for the whole governorate. Our big success here is that this is now included in their health strategy document. So we are feeling very proud for this, because this means services are really closer to women and girls. Another example we have is, it's very similar, from Pakistan, where family planner responsibilities were sat with the population welfare department. We started working with that department, but as well as with the Department of Health simultaneously. We did advocacy discussions on both sides, and towards the end of the project, we were really able to do a functional, operational integration between the two entities. In SID, for example, like in this region, like they really merged and became one entity. With that in mind, we had more success in revamping family planning centers, supporting female healthcare workers, trained them, and as I said, like bringing these services very closer to where women are, which is the household level. So yes, I will stop here, and I know we need some more time if Justin is around or for questions.
Thank you. Thank you very much, Maria. So each of these case studies have described effective strategies and facilitators for advancing SRHR advocacy, policy, and practice in humanitarian setting. We heard from our colleague in Chad, DRC, and Yemen that changing laws isn't the only end goal. It is often the first step needed to realize change and expand access to contraception and abortion care for our clients. We have almost 5 minutes for question and answer. And if it's not enough, I will ask, Natalie has put already that in the chat. So feel free also to just write your question in the chat and we'll find a way also to answer them. But we have 5-minute discussion. So it's open. You can unmute yourself and ask a question or also chat, type your question in the chat. I'll try to check if there is any question already. So there is a comment from Foku Helix. Do you want to open your mic and maybe speak about the comment you just posted in the chat?
Yeah, sure. Thank you. So I'm focused from an adolescent-led movement in Cameroon, which is known Mifali. So last week during the Safe Abortion Day, we plan to carry out an activity to raise awareness on the importance of safe abortion. But we finally decided to cancel the abortion because after doing many research, we came to find out the strict rules and regulations which have been passed in my country on abortion, that we saw the consequences of us doing such an activity, and that was like, it was to be seen by the different stakeholders and government, like calling more people and adolescents to go into abortion. So we decided to cancel that activity and we didn't do anything. So I just wanted to know from some of you here who might have more experience in such, if there's anything that they can advise us on a way we can do the next time in such cases, because of the real risks that adolescents and youth are facing in my country due to unsafe abortion. I personally have already lost 2 friends because of unsafe abortion, and that really, it's very bad, and I'm sure many youths still in my country are dying because of those, but the government still is not doing anything for that. Thank you very much.
Thank you very, very much, Fuku, for this. And maybe I will direct your, so we are closing the session in like 50 seconds. So we might not be able to fully respond to your question. We might get interrupted. So we'll make sure we put you in contact with one of the panelists to address this question so that your concern is addressed. I hope that is fine with you.
Yeah, that's totally fine. Thank you very much.
Thank you very much. We'll make sure we'll respond to that. And again, if there is any other question, please feel free to post them in the chat. And thank you all for being in this session, and see you in the main room. Well, we're already in the main room. So we're just waiting for others to join.
Thank you, Jessica.
And maybe
that's great.
Hi, we're coming back.
Thank you, Jessica.
Thank you.
Thanks, everyone. So hope you really enjoyed Breakout Session 1. We're jumping into the second one. So for those of you who would like to have interpretation, in the main room, there will be a discussion on clinical capacity building. In room 2, we will discuss the minimum initial service package for SRHR. And then in room 3, we'll have a discussion on data use and research. So similarly, you will self-select the room you'd like to join. Remember that you can do so by clicking on the 4 square button in the bottom of your screen. So we'll give folks about 20 seconds to do so, and we'll see you in the room.
Hello, everyone. Welcome in the capacity building breaking room. Just we'll wait for some time for the rest to leave if they are not interested in this room. Okay, I see the number now is fixed in 26. Maybe we can kick off and start our session. First of all, I would like to welcome you and thank you very much for joining this session about clinical capacity building under LAD projects. I'm Dr. Shihab Ibrahim, working with Save the Children. I'm a medical doctor. Start working with Save the Children maybe since 2004, responding to Darfur crisis. And then I have a chance to work in a RAISE initiative and LAD project in Yemen and in other countries. Currently, I'm a health advisor for Middle East, North Africa, and East Europe. So welcome all of you for this session. This session, the structure will be actually divided in 5 parts. The first part will be a general introduction about the clinical capacity under LAD projects. That will be done by me. And then we'll have 2 case study presentations. The first one will be about capacity building for safe abortion care. And this will be presented by Bill Powell. As you introduced by Prof. Teresa, Bill Powell has been with Ipas for over 16 years as a senior advisor supporting Ipas efforts to improve the access to safe abortion and post-abortion care in crisis setting. Bill also has served as Ipas liaison to the IAWG reproductive health group in crisis and participated in so many reproductive task force. Dr. Pell also considered as a co-founder and former chair of the Safe Abortion Care Sub-Working Group. The second case study presentation will be presented by our colleague Augustin Baloko. Augustin Baloko is a medical doctor working with IRC for the past 14 years with long experience in sexual and reproductive health project implementation and support for more than a decade. Dr. Augustin, for the last 2 years, he is holding the position of primary healthcare technical advisor and sexual and reproductive health backstop for West Africa region. So after these 2 presentations, we'll have like testimony videos, 2 testimony videos, one from DRC and the other one from Somalia program implementation there. So at the end, we'll have like a session for Q&A for the audience. If you have any questions, we'll try to find a time at the end. But if we did not find a time, please try to share your question in the chat box and we'll do our best to try to answer it there. So the If we start with the introduction, actually for the clinical capacity building, it is one of the main component of the LAD projects, as we know, and as we heard from different speakers. And the capacity building actually achieved a lot of progress, as we see in the first slide. And this achievement actually done due to a good collaboration and partnership with different stakeholders at the country levels and also at the regional levels and at the global levels. And this includes IAWG Working Group, CARE, Ipas, Save the Children, RAISE initiatives, IRC, and Columbia University. So the project, if you can see in this slide, actually they use, through its life cycle, they use and develop a structured approach actually to track and to monitor the healthcare providers who receive training. And this approach actually includes for each single healthcare provider, they receive assessment in the first 6 months. And this assessment actually it is competency-based assessment to identify the competency level based on a specific mechanism put it to grade the healthcare worker while they are receiving different kind of training. At the end of the year, usually the project provide like refreshment training, and here it focuses mainly in the area what it needs improvement based on the assessment conducted and based on the supportive supervision recommendations that put by supervisors. You can see the next slide. The LAD project actually, they use competency-based training approach, and they start actually by using the RAISE curriculum and start working in the RAISE curriculum to make it based competency. But in addition to the RAISE curricula, throughout the project life, there is a lot of initiatives and a lot of training models developed by the program. The first things I will talk about the VCATs, which is workshops usually developed and conducted by Ipas. And the main idea here for this workshop to explore the participant conceptions about the abortion and to examine also their role in serving women safe access to abortion care. The other things also, other modality or method used is TOT training, and this is based in the competency system. After each trainer reach level 3, then they will be qualified to be a trainer and receive a TOT training and became certified trainer. The third thing is also the project use e-learning and they cover a lot of technical informations and also procedures, and they put it in electronic reforms and share it with the different staff at different country offices. This is also as a collection pools for a lot of e-learning training. The other area also self-learning workbook, and this is like a simple manual developed by the projects and distributed to the frontline health workers. And frontline health workers, they use it to train themselves at the health facilities and identify the gaps that they have. And usually it is followed by qualified trainer visits to complete and to complement the learning process for the frontline health worker. Other things, the flash training approach, where flash training approach is based on supervisors or trainer who conduct a visit to the health facility and try to deliver like demonstration for the frontline health worker and deliver short-term sessions for a small number of health workers, either through anatomic models or showing videos in tablets or conducting some role plays there. The last approach, it was used by the project. It is a sexual and reproductive health clinical outreach refresher training, which call it ESCORTS. And ESCORT is developed by IAWG, and ESCORT actually developed to meet the need for the rapid refreshment training for the frontline health worker and managers, especially in the acute and protracted humanitarian settings. So this is like a collection of approach used by the project to increase the capacity at different levels. Next slide, please. Here, just this slide showing the timeline and development of the clinical capacity building progress during the projects. Just I will go through it quickly. As you have heard in the first presentations, we start in 2006, we start development the RAISE curriculum, and RAISE project also started in some countries, including Darfur and other countries. In 2007, actually RAISE Training Center developed in Kenya with the partnership with MSI, and it started to provide family planning, post-abortion care, and EMOC training. In 2008, you see here the first training held on family planning, post-abortion care, and emergency and newborn health care. 2009 and 10, the training at country level started and cascaded to train, and also developed the TOT training site inside the targeted health facilities by the projects. 2011, there was a review of the national training curricula in DRC and Pakistan. This is the project contributed strongly in revising that. 2012, the first training started in supported supervision, and this is include a lot of stakeholders from NGOs and Ministry of Health staff and others, with support from Columbia University. In 2013, training center established in Goma, DRC, in collaboration with the Ministry of Health there. Next slide. 2016, there was a development of S-Escort manual. This is workshops for abortion. And also in 2017, uterine evacuation with MVA manual vacuum aspiration released by IAWG group and start to be rolled out in 2017. 2017 also, it is first abortion DCAT workshop and TOT for humanitarian partner held in English and French language. And again in 2019, the uterine evacuation model piloted in Uganda, Nigeria, and DRC. This is just to show the development of the capacity building throughout the life of the project. This is the end of the first part, which is a general introduction about the clinical capacity building. I'm going to the second presentation for the sake of the time. Just I want to remind you, if you have any question, please put it in the chat box and we'll try to track it and answer it as much as we can. So now we'll shift to the first presentation about capacity building for safe abortion care, and Dr. Bill Powell, please, floor for you.
Thank you, Dr. Shihab, and appreciation to you all for being here today. And I'll briefly share this case study on how we work to build capacity around safe abortion care over the last decade or so. But I want to first note that the SAC capacity development really benefited from the work previously done by the partner agencies in this project to strengthen post-abortion care, PAC. Next slide, please. And as you can see from the date on this slide, from over a decade ago, SAC capacity development has been considered a need for many years within the IAWG community. Our former colleague, Wilma Dudens, who many of you probably remember and now retired from UNFPA, had advocated for MVA refresher training since the early 2000s. And we fielded a pilot with providers working in the Dadaab and Kakuma camps in Kenya in 2010. That pilot included a refresher of MVA skills, pelvic model practice, clinical updates, and then a short session on the abortion law in Kenya so that everyone was clear on what the law supported and did not. So, and this was very well received by the 40 or so participants that participated in these pilots. Next slide, please. But we didn't have any real funding at that time to move this forward. And so the work of really rolling out the training, the capacity building stalled. And Ipas and others spent a lot of time over the ensuing few years doing a lot of safe abortion advocacy within the IAWG community and externally as well. And then the funding, as has been noted, came to the IAWG in 2015 to catalyze the Safe Abortion Care Sub-Working Group, which opened up a lot of possibilities, led to tools, stronger advocacy, etc. That also helped restart the escort modules, which again stand for SRH Clinical Outreach Refresher Trainings within the IAWG. And that included the uterine evacuation with MVA. And so at the IAWG meeting in Dakar in 2016, there was a training of trainers, actually, master trainers around all of the escort modules, including the MVA one. Those were piloted in various settings over 2016. And then in 2017, all the escorts, including the one you see on the slide for MVA, were released by the IAWG Training Partnership Initiative. Next slide. Now, a major caveat, and this was mentioned in the plenary session earlier. I mean, we know that even with proper knowledge of the legal framework and the clinical skills, providers and others' negative attitudes and fears related to provision of safe abortion care can continue to act as underlying barriers, restricting women's access in crisis settings. And as the quote on the screen that you see there in blue demonstrates, that even when abortion care is provided, sometimes provider attitudes can profoundly affect the quality of the care that the woman experiences. So this is a very real challenge in abortion care everywhere, including crisis settings, but one that we knew could be addressed through the use of values clarification and attitude transformation, or VCAT, materials and approaches. And those have proven successful with abortion care in other settings. So we had, at Ipas, we adapted our traditional VCAT that we'd used for a decade or more. We adapted it for humanitarian audiences and began offering that to our partners in 2017. Next slide. So thanks to ongoing LAD funding to the implementing agency and to Ipas for technical assistance, 2017 is a year that much of the SAC work really took off and the momentum began. And note that the trajectory and longevity of this momentum is sort of to be determined, mostly dependent on future funding and how we're able to keep it going. And that's why I left the question marks there in the top. But as I said a moment ago, it really all started with significant investments in VCAT workshops and then VCAT training of trainers within multiple agencies. And I should also note that this was not just with trainers and providers, but really started with the staff from agency headquarters and regional support and management staff. This organizational change that is necessary to start SAC programming often requires VCAT at all levels of the organization. Following the VCAT, clinical trainings and clinical TOTs happened. And then we adapted, and at Ipas adapted some training models in Cox's Bazar, Bangladesh, to establish safe abortion care, or menstrual regulation as it's known there, and demonstrated that these services could be rolled out during the acute crisis, answering some of the naysayers that had questioned that. The IAWG Training Partnership Initiative undertook a revision of all the escort modules, and through that work, we developed a new module on uterine evacuation and crisis using medications, and then piloted those modules in 3 different humanitarian settings. And then all the escort modules, including the 2 on uterine evacuation, were finalized and released in 2021. There were other regional trainings that were offered, and we actually had a third one that was canceled due to COVID. Next slide, please. So these are some of the results that come from in the top section from Ipas sponsored events. We had 28 unique countries that sent participants, which really showed commitment for improved abortion service quality and availability. We worked with 25 different organizations, the major ones seen here and several other large and many small national NGOs were involved in some of the workshops as well. 29 different workshops were held, which resulted in 653 champions trained to expand SAC service availability. And those workshops, again, included participation in VCAT, safe abortion care, and trainer workshops. And then as an example of sort of cascading results, here are some of the results from IRC's work around SAC capacity building. They, after participating in the Ipas-led events, conducted their own VCAT trainings, and another 900 staff were involved in those, and then over 500 health workers were trained around SAC in various programs by IRC. So a lot of cascade capacity development there. Next slide. And in closing, I offer you 3 direct comments from participants who were in some of these trainings. And I'll read them to you though, since they're not translated on the screen. Apologies for that. A participant from the DRC said, "What would I do differently? A paracervical block before doing manual vacuum aspiration, pain management using ibuprofen, and know how to administer Miffy in combination with Mizo or give Mizo alone." A participant from Nigeria said, "I will change my attitude. I will do follow-up. I will do good counseling. I will have self-confidence, respect for all clients, and provide quality care to all clients, irrespective of age, religion, and marital status." And finally, on the next slide, the participant from Uganda had this powerful quote: "This training has helped us not to discriminate anyone who has come for this service. So you cannot discriminate this one who is young or this one who is old, so you cannot do the procedure. It has helped us to do abortions to any client who really wants the service. I feared talking about abortion, but now I'm okay because sometimes I see people dying. But I think helping these people about abortion is better than leaving them dying. And right now, I have come to really believe that with the knowledge I got, with the medical method and the evacuation, I can really help a lot of people in crisis. And also, I will not feel so ashamed to talk with them, to counsel them, so that I will not lose them." Thanks for listening. And now I'm going to turn it over to Augustine, who will talk about how supportive supervision has adapted and been applied for ongoing support for providers of family planning, PAC, and SAC. Thanks.
You are mute, Augustine.
Oh, sorry.
Yeah.
Thank you, Shihab. I was saying thank you, Bill, for the presentation, and thank you for all the participants who has joined us, listening to us during our sessions. So I'll be taking you through the support supervision tool that we used during the implementation of this project. And here we have the contents of how we were implementing support supervisions. And this is something that was done across all the organizations that was implementing this project. So we going through a quick definition of the support supervision. We look at why is this important, and then we'll see how we used to proceed, when implementing support supervisions, and then we'll look at the tools that we have been using before closing by conclusion. Next slide. Yeah, so we define the support supervisions as being a process, a process that helps us to guide, to help training, encouraging staff to improve their performance continuously in order to make sure that they provide high quality services. And this is something that have been done, on our daily work. I mean, next day. So the support supervision actually is very important. It's important why? Because it helps us to really narrow down the gap between the required competency that we're expecting from health providers and what is his current level of competency. So using the support supervision just help us to get this gap down and address it actually. So it helps us to motivate staff and ensure that they're providing high quality services and that we are detecting and solving some of the problems that may occur, even prevent some of them. So it's like act before that issues arise. It's really helped to train staff and to improve their capacity and perform well. And then we are able to give a very constructive feedback, even monitoring the project implementations. So it helps as well to gather suggestions to improve the process itself. Next slide, please. So how do we do? What's the procedure we go through when we are conducting support supervisions? Number one, we need to prepare for this task. We need to assess the provider competency, and then we have to conduct the coaching, of all the providers that have been assessed. And lastly, we have to monitor all the provider competency to make sure that they're keeping their competency, their skills at an acceptable level. Next. So we talked about tools. So here we have the tools we used during the implementation of this project. We have the paper-based checklist that you can see here on the left side of the screen, and then on the right side of the screen you can see the tablet-based checklist. This checklist has really helped us a lot to assess the competency of the health providers through a direct observation. Next, please. Yeah, and sorry, can you come back again? Here we are showing you how we were able to monitor competency using a database competency. So we have here in yellow and black one of the database that have been used, and the other side you have another one which was tablet based, and this one it was a paper based one. Next. Yeah, so we used a lot of anatomical models because remember, when you are providing kind of support, you may not be able to come across with a real client to provide, to conduct coaching of the providers. So we had a lot of anatomical models that we have been using over the project implementations. So you can see on these pictures. And on your right side of the screen, you can see the e-learning module that have been developed and used.
Right. Augustin, I'm sorry, we have to stop. We've brought everybody back to the room. I'm sorry, we're cutting the group short. But I think, sorry about that. But Sarah Daster from IAWG was going to close for us today.
Okay,
Yes.
thank you.
Hi, everyone. I know, apologies, the breakout rooms were so interesting. It was really hard to fit so much great discussion into that time. So yes, I'm Sarah Naster. I'm the coordinator for the Interagency Working Group on Reproductive Health in Crises, or IAWG. And I have the honor today of providing a very brief closing, very brief, I promise. But first, I wanted to give thanks on behalf of my co-sponsors to all of our wonderful speakers, facilitators, interviewees for sharing their time, their expertise, and their experiences with us. And a huge thank you to you all, the participants, for spending these last 2 hours with us and sharing your thoughts and questions. And lastly, a huge thank you to our interpreters and to the co-sponsors of this event, CARE, Columbia University, Ipas, International Rescue Committee, and Save the Children, and the many other organizations and individuals who contributed to the planning of today's webinar. A lot of work, as everyone knows, goes into these on the back end, so thank you so much. And I'll close today with just 2 very brief reflections. My overarching takeaway from everything I've heard here today is one of hopefulness and optimism, which is especially welcome at a point in history where SRHR feels anything but hopeful. The investments in this work have undoubtedly moved the needle on sexual and reproductive health and rights in humanitarian settings, with clear and compelling progress on voluntary contraception and comprehensive abortion care. We've seen what's possible. And my second reflection is on the power of partnerships between global, national, and local stakeholders. And I would say not just formal partnerships, although those are very important, but informal partnerships as well, relationships and connections. And while the field is in the process of redefining and shifting what some of those partnerships look like and how they operate, an important and overdue shift, it won't change the fact that our partnerships and relationships remain so very essential to our success. And among so many other things, the investment from the donor leaves us with a legacy of very strong partnerships and collaboration. And speaking from personal experience, enhanced capacity of the IAWG Secretariat to support this collaboration. And lastly, while we've heard about the incredible success of this generous and visionary investment, of course, the work is far from done. In order to build on the successes over the past 15 years plus, to leverage the work to date, to put into practice the many learnings, and to keep this momentum going, we need renewed investments for voluntary contraception and comprehensive abortion care services, research, policy, and advocacy efforts. And lastly, we need investment into the coordinating platforms like the IAWG that amplify the policy and programmatic work through our membership and beyond, and support for the role that IAWG plays in the strong coordination and collaboration that will be absolutely crucial in the coming years as we continue to build an enabling, supportive environment for sexual and reproductive health and rights. And with that, I will close. Thank you all so much for your time and attention, and please enjoy the rest of your day.
Thank you, Sarah. Thank you, everyone.
Thank you, everyone.
Thank you, everyone.
Thank you. Bye.
Thanks all.